Hello there again, this is Kamran Popal, and I'm here back again with an emergency scenario, which is TRUS biopsy sepsis. So your scenario is a 67-year-old gentleman in the emergency department with a temperature of 38.2, tachycardia, low blood pressure, and is drowsy. His transrectal ultrasound biopsies were done 6 days ago. How would you proceed? So the way I answered this question was, I would prioritize and ask the referrer to shift the patient to the rhesus area of A&E. I would assess him according to the CRISP A to E protocol and initiate the SEPSIS 6 protocol. Concomitantly, also look at the procedure notes and see if there were any complications, and also see if there's any urine culture on the system. The SEPSIS 6 will include 15 liters of high flow oxygen, 2 18 gauge IV cannula, 2 liters of IV fluids in 500 ml boluses, and look at the response. IV antibiotics according to the TRUS policy, bloods including full blood count, using ECRP clotting, and a blood gas looking at lactate and metabolic status, blood cultures, urine cultures, and inserting a urinary catheter for input and output monitoring. We'll also do a quick abdominal exam to palpate the bladder and also perineal area and the urogenital exam, and do a digital rectal examination. If able, I will take a focused history of infective lower urinary tract symptoms, including dysuria, flank pain, foul smelling urine, and fevers, and also the onset, duration, and progression of these symptoms. I will also check for a history of recurrent UTIs and his performance status. I will ask the microbiologist about appropriate antibiotics, involve the CCOT or ITU reg. When the patient is unstable, I will also inform my on-call consultant, the family and the relatives, and add the patient to the M&M. So these things that is usually comes as a question. So what other teams will you involve? So then you have to say all of these things. What are the common organisms in TRUS biopsy sepsis? Obviously, commonly urinary tract organisms. So you can say gram-positive, such as Staph aureus and Enterococcus, gram-negative, including E. coli, Proteus, Pseudomonas, Klebsiella, Enterobacter, and other rare are Candida, and anaerobes such as bacteroids and Clostridium species. What meeting is usually readmissions discussed in? So the answer is monthly M&M meeting. And how do you classify surgical complications? So there's a very famous system called the Clavien-Dindo 2004 classification system, which divides the different stages of the Clavien-Dindo system into 5 stages, so 1 to 5. And 1 is any abnormal course of recovery which did not need any intervention. Then 2 is pharmacological treatment needed, such as oral antibiotics. 3 is when surgical, endoscopic, or radiological intervention is needed. It is divided into 3A and 3B. 3A is when it's usually under local or regional anesthetic. 3B is when it is under general anesthetic. Then 4 is when ICU needs to be involved, and if it's 4A if it's single organ failure, it is 4B if there's multi-organ failure and needed ITU support, and 5 is death of the patient. So this is the Clavien-Dindo classification. Usually a suffix D is also added at the end if the complication happened at the point of discharge of the patient. So I mean, you don't need to know about the D, but the rest of them it's good to know, and if someone asks you, this will be the last question and this will be your brownie points. Anything above Clavien-Dindo 2 needs to be discussed in the M&M. So Clavien-Dindo 1 it does not need to be discussed, but anything 2 or above needs to be discussed in M&M. Right, so that's the end of our station, and hopefully you've enjoyed and learned from it, and we'll see you next time, and all the best, and hope you all get a national training number.